Hello there, this is Dr. Mintz. I'm going to go over this chest radiograph and give you an idea how I go about reporting cases. I always start out first with the patient's history and then go through important positive findings and also make sure I mention the relevant negative findings, things that look okay. So in this case I would say there's an area of opacity in the left lung base. See, I'm saying lung base, not lower lobe or lingula, remaining somewhat non-committal. A general description, there's an area of opacity in the left lung base. There is partial silhouetting of the left hemidiaphragm. Notice how you can see portion of the left hemidiaphragm here medially and maybe a little bit out here laterally. You're losing some of it in here. You don't really see it well. And there is preservation of the left cardiac border. So this is indicating that it is a left lower lobe process, and the preservation of the cardiac border there suggests it is not involving the lingula. So this suggests it's probably a left lower lobe process, and given the clinical history, it's probably a left lower lobe pneumonia. The right lung is clear, period. Mediastinal silhouette appears unremarkable for technique, meaning that it could be big if it weren't for the fact that it's an AP, not a PA chest, and if there were a better degree of inspiration, you'd expect the cardiac silhouette to be smaller, so the limited inspiration and the AP positioning together tend to make the cardiac silhouette in a normal size heart exceed 1/2 the transverse diameter of the chest. So, in summary, history, 33-year-old female with chest pain and cough. Paragraph findings. There is an area of opacity in the left lung base, period. There is partial silhouetting of the left hemidiaphragm, period. Left cardiac border is preserved, period. Right lung is clear, period. Heart size is unremarkable for technique, period. Paragraph impression, left lower lobe pneumonia. So I've made the description of the findings, including positive findings and pertinent negative findings, in the body of the report. So the impression statement, I think, really should be just that, the impression. What you would say if the referring doctor were to call you on the phone and say, "How's it look?" I would not go through the description of all the findings here and there if I didn't have to. I think it's a left lower lobe pneumonia. I would tell him left lower lobe pneumonia. So what's my impression? Left lower lobe pneumonia. What else would I want to put in the impression statement? If there are other things that people are inclined to put in the impression statement but are clearly stated in the body of the report, I think it's important to realize that the body of the report is a separate component of the report than the impression, and you don't need to repeat everything a second time, which is what many radiologists do, I think. So keep it succinct, clear and to the point, and in your impression, try to make it as simple as possible without overlooking important findings. So in this case, it's pretty much straightforward. You have a young lady that has chest pain and cough. Your impression, left lower lobe pneumonia. Straightforward as that.